Okay. So a couple of years ago, we tried to take a stab at this and put together a consensus document between ACC, SCAI, HFSA, and STS with many people who were on this panel as well to determine how to use these devices. The challenge here is it's a constantly evolving field, and so I think we did a pretty good job of advancing the field here and getting some consensus across the board with my co-chair, Dr. Rihal, but obviously it's advancing, and so I'll take you a little bit along that travel here. So when to use myocardial mechanical cardiac support. This is a table from a paper that we wrote about a year ago looking at the various indications as we saw them at the time. Obviously, patients with complications of acute MI, these can be ischemic MR, acutely depressed LV function, which is, of course, the most common, cardiogenic shock from RV infarction and IMI, ventricular septal defect, severe heart failure in the setting of non-ischemic cardiomyopathy. Some of the big ones here are fulminant myocarditis and stress cardiomyopathy. Some of these patients are very, very sick that you need to bridge them through that. Acute cardiac allograft failure is another one that we see at heart transplant institutions. Post-transplant RV failure due to the ischemia of the thin-walled RV in transport. Patients slow to wean from cardiopulmonary bypass. Refractory arrhythmias is a new one because of the changes that this does both in terms of the ischemic threshold and a decreasing rate of arrhythmias in some of these patients with ischemic cardiomyopathy. And of course, prophylactic use for high-risk PCI, where this all kind of began in terms of support devices in our field. And then now increasingly we're seeing a lot of high-risk complex ablation. That's used pretty frequently at my institution. And of course now percutaneous valve interventions as well. So you can see from that there are pretty much three main buckets for hemodynamic support. There's the cardiogenic shock bucket, with or without acute myocardial infarction, the high-risk interventions, primarily PCI, but now evolving into complex arrhythmias and valvular interventions, and then a whole series of evolving indications that are done in some institutions and not so much in others, but I think that's where the field is going. Certainly, early identification of pre-shock, I was just talking to Tim Henry about that, to shock and to try to avoid that and cessate that process. Door unloading strategies, you'll hear a little bit about that probably at this meeting by Dr. Kapoor. Unload LV in patients on ECMO, so a good amount of activity there in terms of patients on ECMO need LV unloading to minimize ischemia, minimize LV thrombus in these patients. And then treat acute decompensated heart failure, another area that has been much talked about, but how do you determine patients who are not frankly in shock, but might require this to avoid pressors, almost like a debutine holiday, but a support device holiday. The why is actually what we've been here for about 10 years trying to determine. Why do we do this? Do we have data to support these indications? The shock trial you guys have all seen from Judy Hockman, that we were applauding ourselves by the significant improvement in survival in these patients, but from then till now, the 50% mortality is about the same. There is some data that mortality is decreasing to some extent, but we're still in the 40-45% range despite our best efforts. And the problem, you've all seen this schema of shock management where the dysfunction occurs quite early and rapid and results in both ischemia from LVEDP increasing and decreased coronary perfusion pressure, but also the cardiac output and stroke volume decrements that result in hypotension and then a responsive vasoconstriction that then also causes more ischemia and more cardiac dysfunction. And the problem is, especially in the AMI setting, which is the majority of these patients, the relief of ischemia epicardially is probably too late, too little, and these patients continue to deteriorate. So the device benefits in cardiogenic shock are, of course, to support the systemic circulation, and we've defined that now as mean arterial pressure and cardiac power output, which includes that, and reduce coronary ischemia and infarction. And ideally, these have to be done independently of whether you're improving epicardial flow or independently of what's going on with the heart that's decreasing the cardiac function. And so ideally, the support device will do these three things very rapidly. It will decrease EDP, will decrease ischemia both on the front end and back end by decreasing wall tension and resistance downstream, but increasing perfusion pressure by increasing MAP. And then also importantly, increasing cardiac output and stroke volume that results in preserved pressure, preserved systemic perfusion, and hopefully avoids the systemic inflammatory response from happening, which we really don't have a good sense of when that actually happens. And so the whole field is moving towards earlier initiation so you can try to trump all of these things from happening. But here's the problem with the evidence, that all prospective trials have so far failed to show a benefit and generally considered not really feasible in the real world. So we have to go with our gut, and then we have to prove it observationally. And so observational data from US Pella and other databases have given an FDA approval for the Impella in this scenario. And the field has kind of moved across the board towards early initiation of Impella CP or 5.0 and ECMO with unloading of ECMO when inserted. And there's an increasing role of trying to understand when the RV is involved. I think we all have to improve our understanding of that. And optimal management generally felt to require early recognition and guidance by hemodynamics, assessment of the LV and the RV independently and as a team, hypoxemia and mechanical issues, and finally a rapid escalation in coordination of devices and reperfusion. And this is a schema from the paper that we published last year looking at pre-shock, shock, and severe shock. And the problems here are definitions. Where do you define pre-shock, where do you define shock, and where do you define severe shock? So we have all these devices, and it's very clear you have to escalate them, but we need to go back and try to figure out, ideally, when do you put these in? You don't want to put your biggest gun right up front because there are potential complications of these things, and they potentially can't be put in too long. But maybe you can sort of mix and match and try to figure out, ideally, when to do that, but it's going to all start with definitions. How about STEMI and shock? So the guidelines clearly support complete revascularization in this setting, and the guidelines favor hemodynamic support. And currently, the goal is rapid unloading and stabilization, followed by immediately complete revascularization, or as close to that as possible. And so the idea here would have pre-PCI support, routine right heart cath, and weaning down oppressors. And this was tested prospectively, observationally, in the Detroit Cardiogenic Shock Initiative we all heard about earlier this year and made some good news about potentially moving the needle on survival in these patients. This is data from that presented by Bill ONeil a few months ago, looking at 37 patients, so a small number of a network of hospitals in the Detroit area, with rapid unloading, 62% supported with Impella, right heart cath 84%, decreased pressor uses, and they had a survival of 84% to discharge. So proof of concept that this could work. How about high-risk PCI? Well, obviously this is trying to take a tenuous patient and bridge them through a complex procedure. We've heard a lot about this. This is the BCIS study, now pretty old, but showed that balloon pump, at least in the primary endpoint, didn't have much of a benefit, but it did seem to reduce ischemic complications. And at 1 year, there was a trend towards a mortality benefit in these patients, indicating that there might be something here. In the PROTECT 2 trial, we all know, after looking at 90-day event rates, there was a significant reduction in MACE rates of 29%. And importantly, this drove the concept that it wasn't just improving the procedural success, but it had a lasting benefit in terms of reduction in repeat revascularization and improvement in New York Heart Association class. So the idea really wasn't that you're just trying to get these patients through a procedure, but you're trying to get them through a good procedure where you do an optimal result, where you do as much as possible while the patient is stable and try to aim for a longer-term benefit that mimics coronary bypass grafting. So these are the patients, you've all seen this, where the confluence of morbidities, coronary artery disease, complexity of coronary disease, and hemodynamic compromise all come together, and you can take 2 out of these 3 or 3 out of the 3 and find the ideal patient where it makes sense to use support, especially as our learning curve has improved, and really we can do peri-PCI support with minimal complications. So the benefits are to reduce ischemic complications at the risk of procedural bleeding and vascular events, but nowadays experience with the Impella device is sufficient that peri-procedural complication rate is very, very low, especially with if you use the 2.5 or the CP, you do good pre-procedure angiography, and you do pre-close technique in these patients. And really they are aiding in more complete and high-quality revascularization, which results not only in improved procedural success, but ejection fraction, NYHA class, repeat revascularization, and likely even survival similar to CABG. There are a variety of algorithms from different hospitals. You can download some of these online, as I did for this one. This is from Inova Heart Institute, and you can use these at your institutions, looking at a heart team approach for complexity of high-risk protected PCI, and determining a priori if the patient needs a conventional PCI with bailout, and hopefully that should be a minimal type of patient population, or whether they qualify for protected PCI, which again is not just to put in the device and get through what you initially were trying to do, but really to try to take a bigger look at the patient and try to treat every area that's ischemic so that you can have an improvement and a long-lasting improvement. And this does also include then CTOs. And so I think individuals training in protected PCI these days should also train in CTO, retrograde and anterograde techniques, so that you can get the lasting benefit that we're trying to see here. So where are we now? To conclude, there's been a rapid evolution of mechanical cardiac support for high-risk PCI and shock, and I would dare say that these are now the standard of care in these scenarios, and we're just really trying to fine-tune what devices in which clinical situations and how do we define shock and pre-shock so we pick the right device at the right time for the optimal outcome. The expanding indications for high-risk PCI with the goal of complete revascularization for longer-term benefits to get all those benefits, including quality of life and repeat hospitalization reduction. System-wide approaches are now there for acute MI shock, focusing on pre-PCI use, right heart cath guidance, and avoidance suppressors. and new paradigms in acute MI management, as you'll hear later today. While the balloon pump, tandem heart, Impella, all these are evolving, I think you can see what I wrote here, that I think we look at IABP for lower risk, high risk PCI perhaps, and ischemic pre-shock, Impella 2.5 for high risk PCI and pre-shock as per the FDA indications, Impella CP for isolated LV and shock, and Impella CP RP or ECMO LV unloading for BIV failure, and of course ECMO when there's refractory hypoxemia or hypoperfusion, with the caveat that all these patients need some type of LV unloading, preferably with an Impella, but also with a balloon pump in certain situations. Thank you very much.